Hello, welcome. Thanks to those who are joining. We are delighted to be welcoming our guest today, Dr. Uliana from IFG, who is absolute IVF specialist and will be talking to us this evening all about low AMH, implantation failure and miscarriage, and the latest advances in tech, treatment and support to help people on their journey to becoming a parent. So welcome, and please do introduce yourself.
Hello, everyone. Good afternoon, good evening. I know you can be watching from the different locations, probably. Thank you for kind introduction. I am IVF specialist. I've been treating patients all over the globe since 2008. I am Ukrainian. However, now I moved to Europe and practicing in Europe and partially in UK as a consultant as well. And this is my great pleasure to be invited guest for this webinar and talking specifically for this very interesting topic about innovative solutions for advanced maternal age, for diminished ovarian reserve, for patients seeing the issues with the low IMH, miscarriages, repeated implantation failures. So that's my pleasure to spend another hour together with you. And of course, I prepared some information as a presentation, but you are fully welcome to ask any additional question after this on the Q&A session, and then communicate further if you would need more specific consultation or information, or just the second opinion, or more information about something what I will mention during the presentation. So fully open for the further discussions and the consultations. Thank you so much.
Great. Well, thank you for that introduction, and we are very fortunate to have you with us today.
Thank you so much. So as I understand, I can continue now with the slides I prepared, which are specifically related to the topics of the low IMH, implantation failure, and miscarriages. And they are about innovations, fertility care, and the opportunities around, which are quite innovative, which are maybe new, which are limited to be present in some countries due to the regulations. So unfortunately, we know the fact that still patients need to travel in order to receive some kind of treatment, which are very regulated or limited or very expensive in the specific countries. And to this kind of treatment, we still consider to be oocyte donation, mitochondrial donation, which is unique and very innovative technique, surrogacy, and so on. So we will be covering an issue about all these topics. Of course, for women, and even we are spending another hour, and during this hour, we are losing some number of our follicles. I'm saying this always because once we have a meeting or the presentation and we have the audience of the men and women, so fortunately, men are producing their sperm, but unfortunately, women are losing our potential to produce more and more eggs with time. That's why our biological clock is always running, and this is so important to be informed and to make proper decisions in the proper time, as early as possible. But always, this proper time is in the right time. When you came to this point, when you came to this decision of become parents, or you started this journey either a long time ago or just a short time ago, but you would like to know how to optimize this in terms of timing, in terms of the most effective technologies and techniques, this is what we would like to talk about. If we are talking about our resource, so the resource as the number of the antral follicles is given during the 7th months of the antenatal development of the fetus, the female fetus. During we are in the uterus of our moms, we already are given to the certain amount of the antral follicles, which we are going to use during the whole entire life, which is starting in our puberty and ending up with the menopause. During this period, we are having around 400 to 500 menstrual cycles. And during each menstrual cycle, we have one leading follicle, which is triggered to be developed with the follicular stimulating hormone, And our nature knows that we need just one follicle. However, in every specific month, certain number of follicles are ready to be grown. Just the only one which is leading is growing due to the impact of the FSH. All other follicles are, for them, the process which called atresia. So we are losing all the follicles we were giving during 1 month in the end of the month. And during with the menstrual cycle, in the new cycle, we are getting totally new cohort, meaning the social freezing, this which is now so important, and we are trying to talk in each webinar and each meeting with our patients that if you are considering, you need to freeze your eggs as soon as possible, because earlier you do this, higher efficiency we are getting overall. So every month we are having the pool. If we are not using this pool, we are losing this pool. And during the next months, we will get totally new one. That's why having a stimulation or undergoing the stimulation during 1 month after another, if this is advanced maternal age, or we need a rest between the cycles for the younger patients because we need also the follicles to recover and the ovaries to recover. This is still a good opportunity for the patients to be stimulated. Like, we used to believe in the myths that the stimulation will cause problems, and patients usually are trying to limit the number of their stimulations. However, if this is done totally safe and under the proper control with the professional fertility specialist, doctor, so there is no risk, because we can be stimulated technically as frequently as this is possible until this is safe. And there are specific factors, but the doctor definitely will define the factors which are very important. Why it is important globally, and the statistics is showing this. This is statistical data from the UK, which is saying that the average age of the first delivery in the world is increasing by 2 years every 10 years, every decade. And if we all see these statistics, and if we just will follow this algorithm, so after in 2100, which is really close, that's a future for our kids, the average first delivery term will be over 50 years old. Be starting to live longer, and we will be talking about all different techniques of the rejuvenation. We having higher quality of our lives. That's why sometimes we are making decisions of building our families also later, because we prioritize different things while we are young and healthy and active and so on. However, technologies also need to think about these opportunities, which options and opportunities we can give to our advanced maternal age patients, because this is the technological development, and IVF in general is a sphere about the technological development. Just recently I have visited UK, and I've been on a fertility network 20th anniversary, and met there the second IVF mom in the world with her son, and what she was sharing, like, for me, relatively young IVF doctor in this field, it was very sensitive, because she was saying, I was told not to share with anyone what I am in about this process. I was not even sharing with my parents, because this was all under the secret. And after this, there was an era of we were having big question marks about, is it safe? Are those kids are going to be the same as the natural conception kids? Are they going to be clever, healthy? What will be their character, and so on, so far? So now we have all these questions around this, that the technological advancement in IVF is safe, and we can still develop, and every year something new is happening, and we professionally just need to follow what is happening. We need to control the safety. We need to be on the ethical side of this. However, if this is safe and ethical, and this brings the advancement for the patient, we as doctors, we need to be involved in this, and we need to pioneer this, and we need to talk about this and share these opportunities. if we are talking about age, there are other factors which are very important. There are specific parameters which we can rely on, as there is something we can check and we can understand what's going on. So regarding the ovarian reserve, or the opportunity of the patient to produce her own oocytes, there is a parameter, one of those, which is quite reliable and very secure parameter. This is anti-Muller hormone, IMH. We can measure IMH in any day of the menstrual cycle. There is very low variability during the menstrual cycle. So that's easy. And this is, once you decide to do this, you can do this. The value of IMH is correlating with the number of the antral follicles which are available on the stages of the small preantral, large preantral, and antral follicles. What does it mean? Like, we have different stages of the development of the follicles in our ovaries, which we got during the antenatal development. And this pool is developing like the overall folliculogenesis, we used to say that this is 270 days, meaning something we will be talking about lifestyle and what is important for the health and the quality of the oocytes. So something what we are doing today will impact the quality of the oocytes we will be producing after 5 to 6 months. So IMH will not show us the number of these antral follicles on very early stages of the development, meaning if we will measure IMH, we will see what is coming in the nearest future. However, the very early stages we will not be able to see. But this is still very important and very relevant. The high levels of the IMH usually correlates with the high number of the antral follicles, which are ready to be sensitive to the gonadotropins, because this is a very important parameter also for the IVF doctors. Without IMH, we cannot plan the stimulation. We will be blind in terms of which dosage, which medications we would need to recommend to the patients. And if we are having IMH, and in the additional antral follicle count and the age of the patient and the BMI of the patient, we will have all information, professional information, which we need in order to decide about the most effective stimulating protocol. So higher IMH we are having, higher chances of multiple number of follicles to grow. And usually it's, we used to say that 0.1 equal to 1 potential oocyte to be retrieved. So in our practice, I used to treat patients, and most, like, my sphere of professional development was mostly oocyte donation. So I used to treat patients with really low anti-Muller hormones. And we know that even if this is 0.1, still there is a potential to stimulate some oocytes, or single or multiple development. Just we need to select the proper protocol and the share with the expectations and the prognosis with the patient. So we need to be really sure about the probability, and to be transparent, of course, as well. Older we are getting, faster is the decline in the IMH. So there is a table, and you can see it here, like that if we are less than 30, the decline of the IMH is slower. If we are getting closer to 35, 36, and especially after 40, the decline is really significant. Once, for example, we are having 0.3 or 0.5 in our 40s, meaning that within 1 year, we will get it half of this. So that's why every month is so important for the patients in their advanced maternal age, and specifically with the diminished ovarian reserve or the low IMH. If we are talking about aging, it's not only about fact that the IMH is declining and the number of the antral follicles is getting limited or very low, but also we are losing quality of our eggs which we are producing. We are producing an oocyte, but inside the oocyte are very specific fragments, and oocyte is not only cell, it also has very important function, because fertilization is happening inside the oocyte, And in the oocyte, we are having the nucleus, which consists the genetic information about the mom and about the future baby. Once we are getting a sperm in, we are getting just the head of the spermatozoid, which consists also only genetic information which is coming from the male. However, all the environment, biochemical processes, metabolic processes, IVF energy, all potential for the further development of the embryo is coming from the oocyte. That's why while we are losing the quality of our oocyte, first what we are controlling and what we need to talk about, this is the mitochondrial dysfunction. If we are losing the power of the cell, we are having lower IVF success rates, we are having lower fertilization, higher aneuploidity rates, and overall results are getting lower as well. That's why we used to say that the success rate depends on the age of the patient, which correlates with the oocyte quality. And the percentage of the clinical pregnancies for the patients after 35 years old, you can see the green line, it's decreasing significantly after 35, 36, 38 years. We are like trying to be more friendly to our patient age, and that's why we are improving. And this is true, we improving the quality of our protocols and the overall treatment. That's why we feel free to say that now it's like not 35 but maybe 38, but still we cannot stop this process because this is very physiologic, natural process. However, if we are using donor oocyte, and this used to be a gold standard for the successful treatment, very effective and very short in terms of time for the patients with who are not able to produce oocytes anymore, or who were not able to produce high quality embryos or genetically healthy embryos. So oocyte donation is very effective alternative which gives really stable and high success rates. Never oocyte donation should be less than 50% successful. This is without genetically tested embryos. If we are doing PGTA tested embryos, working percentage should be around 70% and higher. Of course, that will depend on the implantation potential. We will talk later about the fact of what is important in terms of the implantation potential. Also, the fact is that the aneuploidity rates increased with age. And there is a data which is globally shared and known, the fact that over 40% for patients who are over 40 years old, the statistically expectations in terms of the abnormalities in the blastocyst are over 70%. That's why this is so important for advanced maternal age, that the clinicians will recommend to do genetic testing for the embryos, because this is part of the success, not only in terms of improving the clinical pregnancy rate, but also declining the risks or limiting the risks of the miscarriages on the way after the implantation happened. That's why we recommend to test embryos as well. If we are talking about alternatives, and this is what I shared on the very beginning about innovative alternatives for the oocyte donation, because once we are using oocyte donation, we are getting 50% of the embryo related to the donor. So there is no genetic information coming from the patient as the female patient. There is a genetic relation to the male partner and genetic relation to the donor. That's why this is psychologically quite complicated treatment to be accepted by the individual, by woman. However, there is a technology which is called mitochondrial donation. In this case, if how this works, this is the technology in case patient still is able to produce her own oocytes. However, quality of her oocytes was very low. We were not able to get blastocysts, or we were testing blastocysts and all blastocysts came back as aneuploid. However, still she is producing her genetic material. For the mitochondrial donation from the patient, we need only spindle. This is the nucleus which consists the genetic information about the female. And we are stimulating a donor at the same time, still we need to do the synchronization for these processes. And we are taking the nucleus. At the same day, we enucleate the donor egg. We are taking nucleus from the donor egg and throwing this away. We are putting the nucleus from the patient into the donor egg, making fertilization and letting nucleuses, both from the female and male, develop inside of the donor egg cell environment. By this, we are exchanging the overall environment for the genetic material to be fertilized, because the mitosis should happen and then the further development. And why, what we understood from the technologies, why there were mistakes on the abnormalities as a genetic abnormalities in the end of the development, because the environment was not optimal. There was lack of the energy potential. There were changes in the biochemical and the metabolic processes in this environment. That's why genetic conditions were also changing. So either embryos stopped their development or they were coming back as aneuploid. That's why this is really successful treatment for those patients who are still producing their own eggs, but they are not ready to consider oocyte donation due to the fact of being non-related to their baby, but they want to have their genetically related child. Also, another opportunity, or what we are doing together or prior to the preparation of our patients to the mitochondrial donation, or just to increase their chances of producing higher number and higher quality of the oocytes, this is the rejuvenation techniques. We used to do PRP rejuvenation since already maybe 6 to 7 years. We believe still that this works. Again, this is very individual, and we need to consult every patient individually in terms of what is the expectation specifically for her, taking into account her IMH, antral follicle count, previous outcomes for the stimulation, volume of the ovary, and so on so far. However, this technique is still effective. But the advancement in terms of the rejuvenation for our facility is the stem cell. Since 2 years, second year already, like over 1 year, we are using mesenchymal stem cells and the exosomes, which we do together with the PRP or just individually without, like, PRP is not practiced anymore, mostly for those patients who have done PRP before. And like a second level of the rejuvenation, this is the stem cell and the exosomes. There is a difference in terms of the mechanism of action. So we understand that the rejuvenation by PRP just increases the blood flow and rejuvenate the tissue in which it's injected. But if we are talking about stem cells, this also brings potential new cohort of the tissue, which is going to be developing and then producing more and more follicles as an outcome. Still, this is quite a limited data, and again, this needs to be consulted individually with each patient. But this is very effective technology, and which is considered to be more and more widely used for specifically for advanced maternal age. Coming back to the mitochondria, so once we are having the battery low, the quality of the development of the embryo will be also very low and very prognostically unhealthy. That's why we are working on exchanging this battery. This is how you can see how the oocyte look like, how we used to see them without the specific equipment, which is very important for this procedure, which called the fluorescent microscope. So we need to see the spindle, its location, and its characteristics. So you can see the spindle very clearly here. And this is once it's seen, and we prepare the biopsy and the specific procedures which are done by the embryologist. Then we exchange this between the patient oocyte and the donor oocyte with the further development. There are two types of the mitochondrial donation as a treatment. One called spindle transfer, and this is what I described before, that spindle transfer is done on day 0, just immediately after the egg collection procedure with the fresh oocyte, after we collected an egg, performed denudation, detected the spindle, and we are having another dish with the same like different oocyte from the different patient, different woman, but also making all the same procedures. And then we are starting the process of the replacement, or that can be pronuclear transfer. Pronuclear transfer technique is done on day one after the fertilization. It's still very effective technology. Technology is the same. This is mitochondrial donation. Just we exchange the genetic material after the fertilization, after 16 hours post-fertilization. So fertilization is happening inside of the oocyte of the patient. In parallel, day before, we are fertilizing donor egg with the partner sperm, and then we are taking two pronucleuses, taking them out from the donor egg and putting pronucleuses from the patient into the donor egg cell environment, and again continue development of the embryo. So this technology is really innovative. As I said, it's still considered to be experimental because I was mentioning 45 years ago just was the first baby born, and that was a total secret. And after 40 years, we have over 6 million kids all over the globe, and the need for the IVF is just growing due to the different factors, aging of the patients, environmental factors, and so on and so far. So that's why we consider this technology as a really technological advancement and the hope which can be given, effective hope to the ones who would like to try this alternative. Um, we have over 30 kids already born as for our group altogether, and patients forced us to talk more about this technology. The first baby, which was successfully born, is already 6 years old. And because this technology is experimental, we were not sharing this so globally, and we're not sharing our efficiency and the results and so on. Now we published already our data, so this is an open data, and we decided to talk about this. This is not easy to be a pioneer, frankly speaking, but we believe that this technology, it's already proven for UK, as you probably know or heard, but it's proven for the mitochondrial disease carriers. So this is a little bit different cohort of the patients, and we also treat those patients that can be mostly younger patients who are proven with the mitochondrial genetic condition, with the carrying the mitochondrial disease. So by this technology, we avoid transferring unhealthy mitochondria to the baby. So, but for advanced maternal age, the reason is different. However, technologically, the process is totally same. After regulations being proven in the UK, recently in 2022, in the end of the year in Australia, these regulations also changed, and but also for the mitochondrial disease carriers, the technology is already proven and acceptable. However, like due to, for example, we are practicing currently in Europe. However, the technology is done in Albania. This is the country which allows experimental treatment technique, and patients are signing the consent for this treatment. So if we are talking about overall some other issues which are related with the implantation failure and miscarriages, still the very first issue and the very first reason is the genetic reason. Genetic reason mostly related or just related to the blastocyst, to the embryo. So we used to, before, or mostly before, we used to transfer embryos day 3, embryos day 2, or embryos which were not tested. So if we don't know the genetic status of the embryo, there is a risk for this embryo of either not being implanted or being implanted and then miscarried due to the factors related to the embryo. So this is a natural selection and the natural conception. Anatomic causes from the uterus, congenital or the newly developed, like the polyps and so on. So for this, hysteroscopy and surgeries would be required, but also very individual cases. And for some cases with anatomic causes, unfortunately, the surrogacy will be recommended. endocrine causes. This is the thyroid dysfunction, hyperprolactinemia, some other issues. So they need to be controlled. They need to be normalized prior to the fact while we are doing an embryo transfer. Autoimmune diseases, very interesting topic. Also, there is a part of the professional society who doesn't believe about the autoimmune infertility, and even we were discussing the fact that we used to call this like not known infertility, that we couldn't detect the cause of the infertility. However, this is the cohort of the autoimmune diseases, and that's why we need to check the NK level cells and the white blood count, and use the immunological protocols for the preparation of our patients, which also we do. And we believe that this can be treated and this can be solved and should be solved. The lifestyle, diets, and the environment, of course, this is something what we much this depends from us. However, some as environmental factors, unfortunately, we cannot change. So we need to understand what are the issues, specifically issues for the specific patient, because and for many patients we have multiple causes. We cannot focus or stop on the first cause which we detected, because that can be also issue with the anatomic causes, endocrine, and the autoimmune, and we need to solve all of them before we will proceed with the further transfer. That's why we always say to our patients that while treating infertility, we need to solve two problems or get into two goals. And the first goal is to have a healthy embryo. Healthy embryo, in our understanding, and this is in what we believe, this is euploid blastocyst. We cannot say that just day 3 embryo, we expect this to be healthy embryo. No, we have technology how to prove that this embryo is a healthy embryo, and this is genetic testing, which is totally safe. Once it is done in the proper laboratory by the proper conditions with the well-experienced embryologist, there is 100% of survival rate. Vitrification is very effective procedure, which patients should not be scared on freezing and sowing their embryos, because if this is a healthy embryo, this embryo will survive multiple times, and this embryo will be implanted successfully if everything was done properly. The same about biopsy. Biopsy is very safe procedure. While we are taking very few cells from the cytoplasmic part of the embryo, we are not touching part of the embryo like an inner cell mass. And from the cytoplasmic part, we are getting tissue which will be forming placenta and other organs, helping for developing the pregnancy. But still, these tissues, they are having the same genetic material as the overall embryo, and they will be informative in terms of providing information about karyotype of this embryo. So this is safe, and that's why it's recommended to be performed. Also causes of the implantation, if we may say in terms of the first goal achieved, this is the healthy embryo, and the second goal is to answer all the questions related to the potential implantation failure, just which I mentioned here, including also window of implantation, including microbiome, including the status of the endometrium in terms of the receptivity and the health. Not proper technology of the transfer, of course, as well. This is very important. And then achieving the clinical pregnancy, proper luteal phase support, which is as well needs to be controlled. So all this plays the role, and all this needs to be carefully controlled and monitored. So as a conclusions, like different treatment options may be recommended in IVF to achieve the goal of the parenthood. As we said, there is an option of the just IVF treatment. However, we need to consider what is the age of the patients and what are the prognostic factors on the overall success. If we do just the regular IVF, we can recommend doing oocyte donation, which is still a gold standard and widely recommended. It's not very easy to be treated using oocyte donation. Unfortunately, in some countries, we still have a waiting list, which is huge waiting list. In some countries, this is very expensive. That's why still patients consider to travel abroad to those countries where there is an immediate availability of the donors and quite reasonable costs. So, as you probably may know, I'm also a clinical director of the Ovagene. So we are running an egg bank, and our goal is to help as many patients as possible. So we use donor oocytes for treatment of our patients, but also sending them to the different destinations, including UK, just to help individuals and to help clinics to help their patients and the individuals there. So second opinion is always recommended due to the specific limits in the countries. This is very true. While clinician is practicing under the specific law and the regulations, and the laws in terms of the IVF, they are very strict in some countries and they are not really patient friendly. However, this development, we cannot stop. Like, we understand the second point of the these micro manipulations on the embryo, that we are so close to the factors of cloning and some other which are not really ethical. That's why this cannot be widely practiced or allowed, because this needs to be done in the good hands and for the well-being of the patients and the overall humans. That's why probably there is some like regulative issues about this, but the technologies are here, and we need to talk about them, and patients need to be aware about options. After they are aware and after they consider everything, they have the rule to make a decision, their own informed decision. The most effective treatment for patients in advanced maternal age is oocyte donation. However, experimental treatments available in IVF are effective and they may be accepted widely in the future. We will be really glad if this happens, and we will solve the issue of the advanced maternal age and living longer. We will be living longer, healthier, and we will be able to build our families also later as well. So there was very important last point. If you are listening to this webinar and you haven't tried all the mentioned above, you should still keep trying, and we will be happy to help you in this journey. Thank you so much, and I am ready for your questions.
Thank you. That was very, very thorough and informative. So I'm sure everyone felt the same. So what tests would you routinely offer for someone who has had recurrent miscarriage?
So the reason of the recurrent miscarriage, if this is not an embryonic reason, so first I would recommend to test the embryos to be sure that we are transferring euploid embryos. That can be the very first answer. If we are sure that we are testing high quality embryos, but still we are losing the pregnancies, we need to do immunological panel. We need to do thrombophilia, and the autoimmune, like the Hashimoto disease tests, and the endocrine profile. So that will be something what will be the most relevant for the recurrent miscarriage.
And how soon after having a miscarriage should someone have these investigations done?
In terms of the histological evaluation of the tissue as an abortion, this is recommended to do like immediately after, and also this can be a solution or the specific answer about what was the reason for this specific pregnancy to be lost. Either again that was a genetic factor or not. So if this was a genetic factor, most likely there is nothing else connected with the body of the mom in terms of being able to implant and to develop this pregnancy further. But if that was a fetus which was tested as absolutely healthy, but this fetus was lost, so the immunological treatment and all other investigations can be done immediately after this information is received.
Am I right in thinking that miscarriages are normally due to genetic makeup of the embryo rather than the uterine, the uterus itself? Is that right?
The genetic factors, they can be easily tested and can be controlled. So we would say yes or no if we have done histological evaluation, or we tested, or if we haven't done the evaluation. So we cannot be sure either this is still related to the genetic factor or not. So then the uterine abnormalities, mostly we know them. So this is not something what is developed rapidly. So if we understand that this is happening and the recurrent miscarriages are happening due to the fact of the abnormality in the uterus, if they cannot be corrected surgically, unfortunately, we need to consider surrogacy. If they can be treated or fixed, so that's recommended to do the surgery, and then after all, continue with the with the implantations further. If this is autoimmune, which is the biggest question mark for sure still right now, because we can test for many conditions in terms of the immune system activity. However, we can still have no answer. Sometimes this is happening because the question is what we are testing and how we are testing. Either we are testing periphery, meaning the blood, or we are testing endometrium, and the specificity of these tests, which are quite expensive, frankly speaking. However, the solution for this is and the mechanism of action. So, what is happening with the immune system while we are having an implantation? Our immune system is our friend. So, her goal is to protect us from something what is considered to be as enemy, like the virus, bacteria, or anything what may be wrong or what may cause the problem for our body. As the immune system doesn't know what is the embryo, because embryo is half not related to mom body, it's related to someone who is husband, partner, whoever, but immunologically this is totally different cell, which immunologically considered to be an enemy. So there is a very active cell in the immune system, which is called natural killer cell, which is the name is very saying about what this cell is doing. So the cell is activated in order to destroy this embryo, which is considered to be an enemy. So, and this is the paradox. Quite often, this paradox is happening for the patients who have very aggressive or very effective immune system. More effective immune system is higher level of the natural killer cells we are having. And if they are too high, they will be destroying the embryo. That's why we need to test. If we are finding the reason, we need to follow the immune protocols, which as well they are different. That can be just the medications which we are taking orally, like the prednisolone or the plaquenil, for example, or that can be intravenous infusion of the intravenous immunoglobulins, which are coming as the factors which are proteins coming from the donor blood, and then they are considered to be the enemies, and they are taking these natural killer cells from the central organs on the periphery. And while these natural killers are busy fighting with the proteins from the IVIG, the implantation, positive implantation, is happening because central organs are free from the natural killer cells. So this is the mechanism which usually works and works quite successfully if there is an indication for the IVIG. Again, this treatment is quite expensive, and but this is effective one. And if there isn't clinical indication, this is helping. For some patients, we need to repeat IVIG because this medication is valid for 28 days. And then even if while the implantation has happened, but the pregnancy is not strong enough until we ended up the first trimester of the pregnancy, while the placenta is fully functioning and supporting the developing fetus. So for some patients, there is a need to repeat this. So usually how we do this for our patients. We know reproductive immunology, so we can recommend type of the protocol and treat our patients. But if they are coming from abroad, usually we are happy to cooperate with the local reproductive immunologist who is helping patients while during the preparation and after the embryo transfer, controlling and supporting the development of the pregnancy.
Thank you for that. Is it best to test immunology issues via biopsy of the womb or the blood? If your blood immunology tests are normal, should someone consider immunology testing via biopsy of the womb?
The biopsy is more relevant. This is true, and this will be we will answer more questions, but also some specific factors of the immune causes we will not be able to receive even through biopsy. So there are some tests which are preferable to be done by periphery blood, by just controlling the blood, but still endometrial biopsy is the preferable option, of course.
Yeah. And what can someone do to help increase AMH after failed cycles? Is there anything?
So this is very interesting question regarding the increasing of IMH. As I said, there is very low cycle variability for the IMH, but it is happening, and I have seen cases with showing the IMH like 1 in January and then 2.1 in April. So these cases are happening. There is no specific cause what can impact this. Like the answer can be about partially the supplements and the lifestyle. So this all works. We cannot say that this is the magic pill and that there is a proper algorithm of what to do in order to increase your IMH. Professionally, like doctors, we are more explaining this with the cycle variability, and this fluctuation or the changes of the IMH is not that significant usually. So it was low, but it started to be a little bit higher than it was before. So this not impacting the cycle outcomes. I would say that while stimulating a lot of patients with the IMH which are quite low, it's sometimes the findings while we are starting the stimulation are more optimistic when we check this patient just with the IMH, meaning there is still a potential. As I said, the IMH is coming from the early preantral and antral follicles, but still there is a potential of some other follicles to come in and to be gonadotropin sensitive and to grow finally. So I would say not IMH is the most important, but the cycle outcome is important. IMH is just the factor which shows us saying, this is the red light, we have it low, you need to do something immediately. This is like a sign, please do. But then what to do and how to do, this is already a decision of the reproductive doctor, gynecologist, or whoever is working with a patient.
Thank you for that. You mentioned sort of the difference between ovarian rejuvenation and PRP, and that ovarian rejuvenation is being used more frequently now. What is the age limit for ovarian rejuvenation treatment?
That's a very good question, because in some countries we don't have an age limit. Like it's not written that there is an upper age limit. So for example, some countries are still treating patients over 50. Just the clinical decision is what is the level, like should it be 52 due to the somatic health issues and the ethical issues as well, or 54 or 56. But of course, most of those patients over 50, they are be preparing them just for the embryo donation or the oocyte donation mostly, because we need to consider what is the status of their ovaries and what is potential of their response. But every patient is so individual. Like we need to talk about statistics, but Still, every case will be very individual, and I'm having several, like already several, because we relatively not working such a long time for, again, the mitochondrial donation processes, but we have several patients in, like, all the oldest are 51, still being able to produce their healthy and nice quality oocytes. Of course, one or maximum two per cycle, and not in every cycle, but this depends on the condition of the patient. If she, mostly those patients who are still responding well in their 45, 46, or even like 42 and so on, they were PCO patients before, while they were younger, meaning they had higher reserve compared to the normal gonadotropic patients. And that's why they preserved this reserve. They had just total number of the follicles that were higher. We had patients producing 12x in her 45 in just one round of the stimulation, with relatively simple protocol, because the protocol also plays the role, of course. So that's why, about ovarian rejuvenation, since we see that patient is producing, is responding for the stimulation, and we are having follicles which are gonadotropin sensitive, meaning that still there is a potential for small follicles to be in the ovaries, because it's not stopping rapidly. And the sporadic ovulations are happening even while we are in the perimenopause, while the menstruations are not regular anymore. So that's why this is, I think here, this is the level of the ethical question. And we consult all our patients. And this is true also, that I had to say or to recommend to the patients, please stop, because this is not effective to continue anymore. We have done everything we could. And that was independently to the age of the patient. That was not only for patients over 45, that was also for patients less than 45. And we need to say, only option is the oocyte donation here and now. But it's very individual. The successful pregnancies in 45, 46, 47 are not single. So this is happening if we have the reserve. So we need to understand what are the inclusion criteria and the factors we are starting with, and then consider what will be the risk and the timing during which we can give time to us as a professional team and to the patient still to work on their stimulations. But what is important, I can say as well, that patients need to prioritize their IVF to everything else, because once they are in their advanced maternal age, their stimulation are not that well planned. They are not that easy predictable as it is for the young patients and for normal responders. Like, we can easily plan patient in one group during the specific time or dates when she is available to fly, but this is true for the good responders or those who are having relatively high IMH. Relatively high, I would say it's over 0.5. But those who have much lower, they need to be available to fly, to travel, to do the hormones, to do the scans as soon as this is needed and as frequently as this is needed. In this case, that will work.
Mm-hmm. Thank you for that. What have you been having miscarriages with donor eggs?
Yeah, that's a good question. And this may happen, of course. This means that the miscarriage is related, or the reason of the miscarriage is related to the body of the woman who is carrying the pregnancy. It's not related to the donor egg if this embryo was tested, because it's also not true that all donor eggs are coming, or embryos coming from the donor eggs are coming euploid. We've been doing a lot of investigations, and in Ovogene, for example, we have genetically tested oocytes. And why we decided to do this option, because we tested almost 2,000 oocytes from the young and healthy women donors, and our cohort donors are between 19 to 30. We are not even include donors in their 32, 35, and so on. So their upper age is 30. And while having morphological assessment of the oocyte, and after that artificial intelligence, because we are using an AI for the morphological selection for the oocyte, and after doing the biopsy of the oocyte, because not only embryo can be genetically tested, but also oocyte can be genetically tested. As a result, for this group of the young population, we have got 14% of eggs coming back as genetically abnormal. Even they looked okay morphologically and they had high score according to the AI. So this is the natural selection as well. Not every egg, even if it looks perfectly, is genetically healthy. So that's why, and of course, like 14, that was the overall. And if we graded between 19 to 30, the highest level, like closer to 14, 12, 14, was between 28 to 30. So we expected over 30, this number to be even more higher, like 15 or 20 or so on. But any clinic or any egg bank is genetically testing the oocytes. They just do morphological assessment and that's all. So meaning we cannot be sure that 100% of the embryos we are getting, even using donor oocytes, they are all 100% genetically tested. And while there is an embryo development, there is also a role of the sperm. That's why we need to test the embryo. So we cannot be sure that if embryo developed until day 5, this is a healthy embryo. No, still this can be genetically healthy or non-healthy. So that's why this is so important. Meaning that if the miscarriage happened while that was euploid embryo, high quality embryo, and this was confirmed, meaning we need to look for the cause as the either abnormality in the uterus. If there is none, so we need to think about thrombophilia. If there is none, we need to think about endocrine dysfunctions. If the TSH was tested and was normal, we need to think about autoimmune conditions and the immune system response, which is already a little bit more complicated, and there can be many questions which needs to be answered.
Okay, thank you for that. And lastly, would ovarian rejuvenation treatment help endometriosis patients with low AMH?
Endometriosis is very, like as we all know, very complicated disease, and the spread of the endometriosis, this is the risk. While we are injecting the needle into the ovaries, if this is one endometrioma clearly located and we understand that there is no risk, of course, we would consider doing ovarian rejuvenation. But if there are multiple, or this is like a stage 3, 4, and patient had surgeries before and so on, so I would not consider this as this is very individual case, let's say. So we have had patients for whom we have done rejuvenation with endometriosis because we are helping to rejuvenate the tissue, which is healthy ovarian tissue, which if we are having an ovary and we are having endometrioma, so this is localized process, but there is another part of the tissue in the ovary which is healthy, or let's say relatively healthy, but still there is no cause of the endometrium there. So if we are injecting the rejuvenation liquid, let's say, because this can be either PRP or the mesenchymal stem cells or the exosomes in this tissue which is relatively healthy, still we can improve the process of the blood flow there and rejuvenate this tissue. But it needs to be, we need to compare the risks and the benefits for this category of the patients.
Great. Really useful to know. Thank you so much. Everything you have explained this evening has been very thorough, and obviously the latest advances in tech. We are very fortunate to have your expertise today. So thank you once again, and thank you to those who have joined. Please do get in touch with the team at the International Fertility Group, IFG, who would be very happy to help you personally.
Absolutely. Thank you so much. And thank you all for your time and for arranging this great event. Bye.
Absolutely.
Take care.
Lovely to see you. Thank you. Bye-bye. Bye-bye.